Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Allahumma sholli ala Muhammad wa ala Muhammad. First of all, I would like to thank the organizing committee, the Gulf Society, APSC, who inviting us to share about the expanding role of the zero fluoroscopy intervention in structural heart disease and congenital heart disease in Indonesia. So the trend now is changing. First of all, we started to prepare the structural heart disease or congenital heart disease using the surgery. And Werner Forsman introduced us about the catheterization. And then now about the zero fluoroscopy. It's all about the dose. The dose makes the poison. So this method is dedicated not only for the patient, but mainly for the doctors who use the fluoroscopy in every day and every moment in the cath lab. So now this expanding role of zero fluoroscopy in Indonesia started from the closure of the atrial septal defect in pregnant women. Now is all spread. Nearly 5 centers in Indonesia have their ability to do zero fluoroscopy procedure itself. This is our initial experience. So, as I mentioned before, we started with the we started to use this method in pregnant women with the secondary ASD. The patient came with a New York Heart Association class 4 and then cannot receive the diuretics treatment since there's some complication with the oligohydramnion. So we started to think, is it possible to put the device? Yeah, I started to do it the classical way, but my friend, my echo friend, asked me to do the zero fluoroscopy. So it's quite easy. It's only 40 minutes procedure, and we can afford this. And the next month, I started another procedures, and Alhamdulillah, this is fine. And now here in Harapan Kita, in our hospital, this nearly 500 cases with the totally zero fluoroscopy septal defect closure. So the most successful is the ASD closure. It's nearly more than 90% successful. And the second one is PDA. PDA is only for 84 because of some technical problem if we do the antegrade transvenous technique. And the most difficult one is the VSD closure because of the curve and then the adjacent tissues. This is our first case. So it's 26 years old pregnant women come with the New York Heart Association class 4. The basic echo showed the ASD secondum with the pulmonary hypertension. After bedside echo, we try to do the right heart catheterization. The right heart catheterization showed the favorable results. And then we continue with the closure. Both were done with zero fluoroscopy technique. The patient is fine, and then couple of next after that, the patient gave birth the baby with a C-section, and now it's in a good condition. This is I share to you about doing the complex cases. This is oval type big ASD, and it cannot be done with the classical technique. So we use the balloon assisted technique to put the ASD, and alhamdulillah it's easily done and it's reproducible. And we know now we have an experience 5 cases to do the balloon assisted zero fluoroscopy technique with in secondary ASD. How about in small children? Since we don't have a TE probe for neonates in our cath lab. So we use the transthoracal echo only for these procedures, and this also with the good results, we can put the AG device. Then this is the most difficult one, is the VSD closure. Yeah. So we put classically we use the transesophageal echocardiography to help to put the VSD. The point is how to cross the VSD. So we use the Judkin right guiding catheter, and then we cross the VSD. This one also the transthoracal only guidance for small children. We can put the VSD device. Then this is the subaortic VSD. As you know, the subaortic VSD is have a high prevalence in Asia. So the Asian population, a lot of subaortic VSD and doubly committed subarterial VSD. So we can put, since we use the new device, this Conar MF multiple pros occluder, so it's very easy to put even with the retrograde transaortic approach.